let's start. So welcome everybody. So I'm glad to start this next our FHIR meetup, which is a part of HealthDevHub activity. So we are discussing bleeding edge topics in health IT and health dev. So and today meetup is dedicated to FHIR and access control, which is real challenge, and I think is very important for adoption of FHIR technology and for interoperability. So so you're welcome to join GitHub community, especially you're welcome to join FHIR community. If not yet, go to chat.fhir.org and join FHIR community. If you have any hot topics you want to discuss, please reach out to us and we will make another meetup. So we love these avant-garde topics. And we have an amazing list of speakers today. So John, Josh, Mohammed, and I don't think I'm going to spend more time on introductions. So let's start. So we have 4 talks and then roundtable. If you have any questions or topics to discuss, please send the questions to the chat, and the same about questions to speakers. So we kind of have like 15 minutes for presentation and 5 minutes for question, or 20 minutes for presentation and no time for questions. So then we can move it to the roundtable. So let's start. John, your turn. Screen is yours.
Sure. All right. So I'm going to start with a rather deep topic, and that is, how does one use the FHIR standard to support privacy consents? And what I'm going to be speaking to is an implementation guide from IHE. It is a implementation guide using the FHIR consent resource. I am, by the way, co-chair of both security work group within HL7 and in IHE, the IT infrastructure. So this kind of fits extremely in my wheelhouse, and I'm super excited that the idea is even useful enough for a webinar like this. So I'm pretty excited that it's coming a little bit into more interest. So I did go to the next slide. There we go. So I'm going to cover this. It's kind of a little bit longer than the time allotted, so I'm going to skip through a few of these slides. I'm happy to make the slides available. They're available through the IHE as well. So the foundations, I'm not going to cover too much because it's going to be covered by some of the later presentations. Within this PCF, Privacy Consent on FHIR, is support for capturing consents, support for various kinds of consents, support for making authorization decisions and enforcing parts of those decisions. So generally speaking, what we looked at within IHE was, simple consents that might be used within an organization. These are not too common, needing to be in a standardized format, because if it's within your organization, you kind of, it can be an internal affair, so to speak. But we then get into this question of, well, is there a centralized consent, authority? Is there some place that can be available within a health information exchange for consents that cover the whole health information exchange? Consent authorizing just data requests, basic consent, things like implied consent versus explicit consent. Some people call those opt-in, opt-out, but I do not, because those terms opt-in and opt-out are very ambiguous. And then what I really wanted to hit upon with this implementation guide was these intermediate consents. So there's some consents that are quite easy to do with OAuth and residual policies. And then we get into advanced consent, which really uses the data tagging that you're going to see some discussions later on. So I'll probably not cover that too much, except to explain that they're in scope here, and watch the other presentations for how that happens. Not going to go into policy, but that's just, how IHE lays things out. So first thing up is we have an appendix that talks to writing of privacy policies. And this is not really interoperability. This is fundamental blocking and tackling, so to speak. Who gets to do what? Who gets to do what when there are consents on file? And what happens when you have conflicting consents? These are some use cases that the policy world has to work through. And if you don't have that, it doesn't do you much good to be talking about consent, so to speak. These are usually based on RBAC, or more likely ABAC, attribute-based access control. Do you need to concern yourself with break glass? Who has the authority to break glass? What happens when they break glass? Is there some follow-up to make sure that that breaking of the glass was appropriate and handled appropriately. And then audit logging is something that I'm a big fan of. If you can't track what's actually happening, you don't know if too many people are using break glass just simply because it seems to get in their way. This I'm not going to dig into, but security labeling services are important. I think Mohammed will get into this, but the idea is, how do you find within your whole data set what are some stigmatizing pieces of information, and how do you tag them so that they can be used? Oh, here I am at the beginning of the privacy consent on FHIR. That was a lot of the background material that is necessary to get us going. And first up, we start with use cases with, how does one record that a consent ceremony has happened? The patient was given a set of choices, they selected from those choices, and that gets captured in a privacy consent resource. Supporting of the maintaining over time. A lot of times consents need to be updated because new policies or new workflows, or now all of a sudden the organization has machine learning that they want to train. So privacy policies change. So how do you maintain that over time? And what effect does that have on access control? And then part two really gets into enforcing the privacy consents that are recorded. What we did was we integrated the enforcement into an OAuth flow. So we're kind of used to Smart on FHIR as an OAuth flow, and we integrate this in. It's no longer just Smart on FHIR, it's Smart on FHIR Plus, those kinds of things. So this is the set of actors and transactions that IHE privacy consent on FHIR comes up with. And I'll get into each of these in the coming spaces, but off on the left, you see the recording of consent. And then the dominant, three things in the right middle is recognition of an OAuth triplet. So you have your client, it wants to access some kind of resource, and it needs to go through some authorization server to get access to that. So within PCF, what are these transactions? Well, the capturing of consent, we did kind of take the easy way out, and we said all of the hard stuff is going to be handled inside the consent recorder. It's going to have to figure out how to interact with the patient. It's going to have to figure out how to present the alternatives. It's going to have to figure out, maybe does it utilize privacy preferences that the patient may bring to the table. All of that complexity is inside of the consent recorder, and it's also responsible for making sure that it doesn't allow something to be recorded that can't be enforced in this particular organization. So yeah, we cheated there. There are some efforts to go ahead and try to address that. I think FAST has a project that's looking to try to address that. But that's a whole lot of user experience, application behaviors. And from an interoperability perspective, we just wanted to say, well, okay, you record your consent resource. It either meets one of these profiles or it doesn't. And within this organization, it meets the requirements that can be enforced, those kinds of things. So it's just standard create, read, update, delete, and search. So it's nothing really shocking here, except we do have a number of profiles on the consent resource, which is up next. And I'm not going to be able to get into them in the time allotted, but essentially, we have them broken down into these four areas. And the first one really isn't profile on consent. The first one is just recognizing that there are some basic policies that you build upon. So we defined a policy which is could be further refined within an organization for the normal treatment, payment, and operation. Another one that says normal activities at this particular. Another one that says nope, I'm not allowing my data, but I will allow break glass. And another one, which we expect not to be picked too often, which is deny all. I don't even want break glass to work. Let me die if the doctor thinks that he can bring me back to life. We have to start with those basic groups because until what is normal, you don't really know where to go with this particular patient. So then the first of the three groups, explicit basic consent. This is really just, a core consent. It has a time frame maybe. So this consent is only good for 2 years. It has, maybe a listing of who is authorized to see the data, or specifically who is not. It indicates who gave the consent, because consent typically is thought of as being given by the patient, but in many cases, there is a reason for some kind of a delegate who gives the consent, because the patient might not be of age, might be too old, those kinds of things. And then what are the purposes of use that are authorized? There's really not much that gets specialized on a patient-by-patient basis, but you have the ability within there to indicate when the consent ceremony happened, when does it need to happen again, who was there, those kinds of things. We then have this explicit intermediate group. This is where we start to bring in some of the simple vectors. And I'm going to say simple vectors because it's things like data that was authorized in 2014, I do not want you to show, or this particular, I do not want you to show. And then, obviously purpose of use is always a good vector to have available to you. So these are some pretty simple. They don't require security labeling services, because they're leveraging the fact that all data within FHIR has these concepts of when was it authored, what is its identity, who authored it, and does it have a relationship to an episode or an encounter. And then we get into the advanced, which leverages security labeling services that have classified the information into alcohol abuse or substance abuse or sexual activities or what have you. There's some concepts. And you could have a consent that says, hey, I'm okay with the alcohol abuse, but there is this stigmatizing concept I don't want shared. So that's what this group has the ability. And then clearly being able to combine things and say, hey, within this time frame, but also this particular security label. So you can have combinations. So we now have to do access control. And this is the diagram on the right-hand side that I showed you before. Predominantly, it is made up of the classic OAuth triplet, except that it has these additional consent authorization server, which is utilizing the consents. They're coming in from the left-hand side there to help with making the access control decision. And it can outright say, no, this particular scope being requested is just an outright no. Or it can say, yep, no problem, nothing in the way. Or the worst case scenario is we need to trim the scopes a little bit, but we also have to give some residual rules to the grouped where there's a consent enforcement point. And this is, we embed these rules in the OAuth token, so they flow over to there under the normal means. And yes, there has to be an agent over there that understands how to read these things and is going to enforce those rules. And again, don't expect it to enforce something that it's not designed to enforce. But the idea is that you can pass some of these particular things. And oftentimes it's things like, hey, if this, data object ever shows up in a search result, remove it. Or if anything with this time frame shows up in the report, remove it. So it's usually those kinds of examples of just remove it. This is a diagram. It's in the PCF. I don't think it's going to do us any good to try to drill into it. But the idea is showing what I've been kind of verbally going through, and it's kind of showing how these various actors dance, how the consent, having been profiled, interacts with the extensions in the OAuth, those kinds of things. And then this is another eye chart, but I think it's the place where I'll spend just a minute that I have. I think this is my last slide anyways. But you can see on the left-hand side. So this is, for example, I am okay to allow normal treatment, payment, and operations, but not any data that's been authored by Dr. Bob. So what you have is that we're saying, hey, this is based upon some fundamental base policy. It starts with a permit of treatment, payment, and operations, and then it has a sub provision in here that says deny data which is authored by Commissioner in this case. So it's actually, not that hard to understand. And that's kind of why I put it on the slide, because these do get a little bit more complex. And then when a data request happens, you can see that the deny authored by Dr. Bob is not something that you can put into a classic OAuth scope. So what we do is we have an extension, and IHE, IUA has their extensions. That's where we stuff the purpose of use stuff, because it's part of IUA. We didn't have to invent that. But here we have this additional extension, IHE PCF, and it is indicating that the patient ID is this patient. Where did this policy come from? Well, this is the consent. That's this thing over here. So it's using a FHIR ID of that consent. And then there's this residual section, which says deny data authored by Dr. Bob. So this is all that needs to be unusually handled at the FHIR server side, in that additional resource server side agent has to be looking at all the data that comes through for anything that was authored by this particular this particular reference. I would normally go into a hands-on, but we don't really have the time frame. But by all means, go on into the PCF, take a look around. There's a lot of examples in there, both for consents and the way in which the OAuth would look.
Presentation, and I think we can spend like a few minutes.
Sure.
The questions. Yeah, so we will reduce our discussion section. So I don't know, Steve, maybe you can tell your question by voice.
Okay. Which Steve are you talking to?
Steve Lane.
Oh, okay. Sure. Yeah. I had basically I did ask the last question, just are we going to be able to get the slides and recordings posted to the website so that they can be easily accessed? That was one question. The other question was that there is a lot of wonderful information here. And I thank you again, John. Every time I listen to you, I understand it that much better. But I'm curious whether there is a kind of maturity model or proposed development pathway that implementers could follow, especially as they're trying to deal with federal and state privacy requirements that would allow us to sort of do the minimum necessary using the appropriate tools initially, and then build this out over time to provide greater functionality.
Yeah, so I guess my initial reaction is it's going to very much depend on your technology stack, right? But that's the whole purpose of having basic, intermediate, and advanced, was to kind of indicate that basic is really very powerful, but doesn't put much additional burden on the infrastructure. It kind of turns into a go, no go kind of a situation, but at least it gives this ability to have consents and have consents time out, have consents specific to purposes of use, which does enable things like being able to have a consent purely for a research project. Intermediate, I think, is the next level, and advanced is certainly much harder, but maybe the talks after me will prove that's even easy.
Thank you. And here maybe, Josh, you can express your doubts about that intermediate can be expressed without security labels.
Yeah, I mean, this might even apply to the basic area, but just to pick on one example, something like an episode of care, it might be very expressive to let an individual say, I'm interested in sharing my health data, but none of these problems, related to my particular episode of, treatment around a substance abuse case. That makes a lot of sense to let individuals say, but I don't think that data are consistently associated with an episode of care like this. So even though you might be able to write it down in FHIR, I don't know that you could really deploy a system like that in a real clinical environment.
Yeah, and I think this is very healthy skepticism, and I'm all for it. I just worry that this healthy skepticism is being used to prevent any improvement. So I think if we were to go forward, we would find some things slip through the crack, no question. But I think we can benefit by moving into the space where we have, intermediate consents. And I don't think there's any absolutes.
Yeah, no, that's fair. We have a very low bar today in terms of functionality that we could improve on.
Okay, and maybe Jason, can you tell a little bit more about FAST Consent Working Group? So just announce it.
Yeah, so it's kind of in there, right? The second and fourth Friday of the month for meeting as a consent. I'm not one of the chairs, but just trying to participate there. And yeah, we're just trying to put what different types of consent are in scope and out of scope. Does it come from patient to provider, provider to payer, all those different use cases. And as mentioned, there's a lot of good discussion this last week, and we're interested on taking that, to the next level.
And what
Working with John's stuff on that as well.
Are you going to with all this?
Yeah, that's the goal. I mean, I think we're on meeting 2 right now in the process, so it's very early, so we don't have like a timeline on what that's going to look like. I think we're just trying to figure out scope and like what work we want to try to accomplish, and then we can have a better idea of like what the outcome is. Is it a full? When does that IG come out? All that.
Yeah, that's amazing. So, and John, do you participate in this working group?
When I can, yeah. Unfortunately, I think the time slot conflicts for me right now, but I participate as much as I can.
Okay, so I think let's stop for now. So everybody welcome to working group. Everybody welcome to put some questions for the later discussion, and we move forward. Josh, so your turn.
Great. Let me just set up my screen share here, and I'm going to present on a small grab bag of topics, but I promised you that they are related. So we're going to spend a little bit of time looking at the micro details of access control policies, and then try to describe where that fits into a broader space of user experience. So there's a lot of things that we can say over the wire and write down in FHIR expressions, but what does this mean for real human beings who want to make sharing decisions and maybe share some of their own data for specific purposes? And then zoom out a little bit more and talk about some of the cross-organizational policies. And in particular, I'll use TEFCA as a small case study for cross-organizational exchange. So you've got the links to all this if you want to follow along on your own. But I'm going to start off with some of the capabilities in the Smart App Launch specification. And it's worth saying this is sort of technology that is very broadly deployed today. So in the US, this is part of our certified EHR testing program. So anybody with a certified EHR will be able to do these first things that I'm talking about here when it comes to granular scopes, at least at the resource level. And then we can get down into things like categories. So the Smart Implementation Guide describes scope language that allows you to approve an app to access certain subsets of data. And the language basically consists of what we call kind of a level. And we'll talk about examples here. A FHIR resource, so what types of resources are we talking about sharing and read them? Or are you allowing a client to create them and update them and delete them? And then if talking about just one resource category alone is not enough, we also allow these to be narrowed down using FHIR search parameters. So for example, using this scope language, you might say something like patient/observation, this should say R or RS. I'll fix that in the slide, and category equals vital signs. And what that means is that you're going to allow a client application to read and search for FHIR observations if those observations have the vital signs category attached to them, and only for the specific patient that is in context in your authorization. So we call this a patient level authorization, and it covers a really common case where an app has been launched in the context of a single patient record. So this could happen when a doctor is opening one patient chart in the EHR, or it could happen when a patient is sharing their own data with an app of their choice. So that's the basic that we have. And the example I showed you so far was patient level. Let's talk about user level for a second. So here we don't assume that there's just one patient that the app will be able to access. Instead, we look at this as a delegated scenario. So the end user, the person at the keyboard, or if I am a parent and I have access to 2 children's records, well, I want to be able to share those 2 children's records with the app. So we call those user level scopes. And they really highlight the idea that smart scopes are grafted onto some existing access control system. So like there's an EHR or a patient portal that already knows who the users are and generally knows what kinds of data those users are allowed to see. And so Smart provides a delegation mechanism so users can share the access they already have with these apps of their choice. And then finally, we have a system level. And this accounts for a scenario where there might not be an end user in the loop, but we just have some kind of a backend service running on a machine somewhere that's able to issue queries directly to another machine somewhere. So maybe you've got a lab interface engine that's receiving results from an outside lab system and posting them into the EHR. And there's no human sitting at the keyboard approving that access as it flows. So that might be a system level scope. And with this language, you can say reasonably flexible things. So you can say things like, I want to provide read and search access to all vital signs about the patient in context. Or maybe you've got a family member who's managing immunization appointments for all of their children. So that app might be able to access immunizations with user level scopes. So that might pull together the immunization schedules for your 2 kids and allow you to see those on the same page. So you can consolidate the appointments that you're trying to book. Or in the case of the lab interface engine, you might say, I'm allowed to create new observations with the system level scopes. So one system connecting directly to another in order to be able to post data in. And that's very common for kind of business to business integration scenarios. So those kinds of scopes are part of the current certification system in the US, and EHRs need to provide access at the resource level. And then also for a few resources like observations and conditions, the requirements are coming in at the category level. So it's fairly coarse-grained. I can't say things like, I don't want to share observations from the year 2020 if they had to do with a certain diagnosis. You might be able to write that down with a smart scope, but we don't expect that real EHRs are going to be able to support those kinds of dynamically constructed scopes. Instead, we have a finite list of them that are just resource types and categories that are published as part of FHIR US Core Implementation Guide. And that serves as the basis for consistency in these real world systems. So I want to call out one challenge with this scope language, which we've heard from a number of implementers who are maybe building their own FHIR servers or using native FHIR servers to do more than just providing access to something like US Core FHIR data. And this challenge has to do with what FHIR calls custom operations. So FHIR has essentially its own RPC framework called operation definitions, where a server can advertise that it supports certain operations, and the operations have a name and some inputs, and they can produce some outputs. So in Smart, we don't have a standard way to express permission to execute a certain operation using a scope. So you might want to call the bulk data export operation on a group of patients, or in order to get an exported data set about all of them. Or maybe you want to call the purge operation on a specific patient to say, I want to make it look as though this patient was never in the EHR, erase all traces of that patient's history. Or an example that somebody shared recently on Zulip, maybe you want to give a back office staff member very specific permissions, like maybe you've got an update name operation, and you want to say that this staff member can, just have access to that one operation to make targeted changes to a patient record. It's very difficult to account for all of the variability in what you can do with FHIR operations in a standardized kind of scope language. So one thing that's important to understand is that these FHIR operations can attach at different paths in the server. So you can have some operations that you call on the server root, or some that you call at the resource type level, like group/export. It's not associated with any particular group in this example. It could be, that would be the type instance level. So if I want to export all the data on group number 17, that would be attaching at the instance level. So there's one point of variability. Another one has to do with the input parameters. So maybe you want to say that a particular user has access to call this operation, but only with certain kinds of inputs, restricted in a certain way. So your scope language would need to be able to say something like those restrictions on the inputs. And so for all of these reasons, we have not yet tried to standardize a scope language for custom operations. Our kind of simple advice right now is if you've defined a custom operation and you want to use it in OAuth scope name. So, right now our advice is just use your operation definition as a scope name. If you need to attach more restrictions, you can come up with a syntax to do it that makes sense in your use case. When we look ahead, when I think about how we can make progress on this over time, one area where I think we could make some meaningful progress is to focus on the data access rather than the specific operations that you're allowed to call. So it'll take the bulk export operation as an example. You can actually describe who's allowed to call these operations pretty well just by describing the data access patterns. So if you want to export data on a group, you'd better have access to the group and the patients in it. And so you could actually attach your permissions to the underlying read access to those groups and patients. Rather than having special permissions for export, you just say export is an operation you can do when you're allowed to read the data. And you could do something similar with patient update name. Rather than saying we've got this special operation and I'm going to give you permission to call it, we could say, well, this operation is always governed by who has update access to the patient address element. And that gives us a target for authorization policies that is a lot more consistent. The surface area is narrower. I don't know exactly what the syntax would look like for that, but it could be something like the example here where you say, I'm going to give you access to update patients, but only at these specific paths within the patient resource. So if there's interest, that's a concept that we might try to take forward with a future publication of smart scopes. So that's the sort of narrow, nitty-gritty scope language part of the presentation. Now I want to zoom out and say that from a user experience perspective, it can be really complicated to manage these kinds of scopes and approvals. And if you're a patient, accessing your own records from an app, you can come up to a scenario where you are trying to provision access to a health system. And I'm going to see if I can do a quick demo here of just sort of sharing my own health records from my own healthcare provider organization. This is one where the app requests access to basically all the scopes it's allowed to under FHIR US Core, which is a whole bunch of categories. And the Epic MyChart interface displays a couple of screens. One that tells me as the user a little bit about the app. This is self-reported data from the app developer. And then there's this checkbox page, which shows me all the categories of data that are being requested and allows me to sort of check and uncheck them one by one. And if you drill in, these sort of correspond to the categories of data that are made available in FHIR US Core. So immunizations is at the category of a whole resource type in FHIR. But when it comes to observations, you can see these are being grouped together. Lab results, smoking status, vitals, these are 3 different categories. But over time, as this system is updated to support granular scopes, there will be probably 3 different checkboxes here, one for each of those subcategories. And you can see from a patient perspective, this is on the one hand, empowering. I've got so much choice. I can really tailor my access policy in a way that makes sense to me. But on the other hand, it can be overwhelming. I've suddenly got 40 checkboxes to deal with. And if these defaulted to unchecked, instead of defaulting to checked, you might imagine that most apps never got or would never get most of the data they needed because patients wouldn't realize that they had to individually check all these, or they might not know exactly which ones were important. So this user experience really dictates a lot. And then at the end of the day, even if we have fairly granular scopes, there might be some things that are really hard for me to say as a patient, like maybe I want to take away data about pregnancy or smoking status or drug use. If we don't have predefined scopes for those things, there might not be a consistent way to say it in different health systems. So I do just want to say that all of this user experience around sharing access to data where it sits has these kinds of limitations. There are other user experiences that you can build around health data sharing, and they have their places and purposes. So one example is a project called Smart Health Links. This grew out of work that we did as part of a pandemic response to help individuals share their COVID vaccine histories and COVID lab results. And in that context, we wanted to give consumers the ability to save a copy of their data and share that specific data set when they chose. And we had a system of doing that with QR codes that was called Smart Health Cards. And this new work with Smart Health Links builds on that, but it allows the consumer to put together a data set that they want to share. They decide what's in the data set. They might use their own apps and tools to put together a bundle of data that makes sense for a particular purpose. And then once you define that bundle of data, you can share it in a standardized way. So this Smart Health Link example here points to an encrypted file with my FHIR observations. In this case, it's going to be showing my own blood glucose measurements over the course of the last couple of months. So anyone with this link can automatically download a FHIR bundle. You can write like a 10-line JavaScript program to turn this link into a FHIR bundle with, in this case, about 6,000 granular FHIR observations representing specific glucoses at points in time, as well as high-level summary observations with these kinds of statistics, and also a PDF of everything you see on the screen here. So anybody with this link can automatically turn the link into that structured data payload. Or if you don't have software that knows how to process Smart Health Links, you can just open the link in the browser and see something like what you've got on the screen here. And if you want to see what the data actually look like, you can click this download button and you'll get that whole bundle with 6,000 resources in it. So I call this out as a different sharing mode. It's not suitable in all of the same scenarios that you might use something like Smart on FHIR for, or something like TEFCA for, but it's very powerful for the places that it works. And it kind of flips the sharing paradigm on its head by allowing consumers to be in charge of what goes into the data set rather than trying to filter things at the time that a query comes through. You don't need a very expressive formal language. You can just make decisions, and then those decisions result in a data artifact. So that's Smart Health Links. And I should say this is a specification that was community developed, and it's currently going through an HL7 standardization process. So the goal is to bring this into the HL7 ballot for the September cycle. So if this is interesting to you, that's a place where you might want to follow up. And then the last quick topic that I have here has to do with network-based exchange. And here the policies are really interesting because the way it works in the US today is that organizations kind of sign on to these networks by forming agreements with each other. And there's a common agreement, that's the CA of TEFCA, that tries to provide some consistency in the way that these work. But essentially the agreements put in place certain policies about who's allowed to query for what and under what circumstances, and who's required to respond to these queries. And basically the way these networks work is that once organizations sign into a network like TEFCA, they become a participant or a sub-participant in the network. And then you, let's say as a healthcare provider organization, can send every other healthcare provider in the country. And you could say in your query something like, I'm seeing a patient called Josh Mandel. He was born on this date. He lives at this address. Do you have any information about Josh? And the idea is that, thousands or tens of thousands of organizations would see your query and decide if they had information that matched the patient you were asking for, and respond with a set of details like patient IDs that would allow you to then follow up and request documents about that patient. And if you think about the permission model here, it puts a lot of trust in these network participants, expecting them to do the right thing and follow the rules. And that is really nice in situations where it works, but it quickly gives rise to these kinds of gray areas where you might see somebody sending a request. The network participants don't necessarily get a chance to review it and think about it and apply a sanity check. They're supposed to just respond because the query is coming from a network participant, and network participants have agreed to only act in good faith. So you could see where this might break down. And there's a recent case that I won't go into the details of, but where one participant in the network was sending out queries that other participants decided might not really be related to patient treatment, even though the queries purported to be about patient treatment. And this points to this kind of trust decision. And right now, the way these trust decisions get adjudicated is that the TEFCA coordinating entity can sort of look at the facts and try to make a judgment call. And as soon, if they can't agree, then ONC can get pulled in and asked to adjudicate any differences of opinion. But from my perspective, one thing that's really missing here is a role for the end consumers, the data subjects, the individuals whose data are being queried and shared every day. And I'll say just really briefly, for me, there's three principles that it would be very good to build into TEFCA with respect to individuals. And I think this kind of transparency could lend to much better trust in the network and better functionality overall. So one is that individuals should be able to see their own data. And in theory, this has been part of TEFCA since the beginning, but in practice, you still can't do it. So it's a good principle. I think everybody pretty much agrees with this one, and it's even part of the rules, but still not really working today. The next one is that patients should be able to tell when their data are being queried. So like as a patient, I think I have a right to know, did somebody just broadcast a query to 10,000 clinics asking about my data? If 10,000 clinics were able to receive that request, I should be able to see it too and know when that is happening and who's responding to it. And this principle is not really one that people seem to agree with very broadly today. This is not baked in the rules of operation or the expected TEFCA functionality. And I think it should be. I think that's an area that we could really dig in. And the third is, I think that to be accountable to patients, we also need to give them some controls over what data gets shared. And in my ideal world, that would look a lot like what John showed in the last segment. You would let patients describe what's not supposed to be shared and with whom. I think we should try to get there. But in the absence of that kind of rich functionality, I think we should at least give individuals the ability to opt out and say, you know what, I don't want my data being shared automatically without me. I'll take the responsibility of moving it around myself if I think that's important. And I don't know personally whether I would take that option, but I think offering that option is just part of what it means to build a system that is accountable and transparent. So out of these three principles, this first one is the only one that TEFCA is at least trying to meet today. The other two really haven't been agreed on by the community as something that's important to build. So those are three topics. I hope it gives you something to think about, and happy to follow up in the discussion afterwards.
Thank you. At least the last is a huge topic to discuss, so we can spend hours and hours. So maybe let's answer one question from Mark. Can you formulate it?
You may have touched on it, Josh. I was looking in, as I'm writing the specs for payer data exchange, we're dealing with potentially system-to-system exchanges that may want to be scoped. So I was trying to come up with a smart compliance scope for effectively maybe querying. You could be querying a group resource, but you maybe not be at the ID level. And you, for example, we've got a member match operation that you want to be pretty open, supply a bunch of data. Do you match any of these members that I've sent you? The data export operation that should be restricted to the IDs that you have got permission to use. So basically at the group/ID level. And, I was just trying to come up with a terminology based upon what the great stuff that you've done. So definitely would take any insight. I think it is something that is needed to be able to consistently define the access to operations and scoping that, particularly for system to system, that it shouldn't be just open access.
Yeah, so thank you for raising this. And I totally agree. It shouldn't be just open access.
Yeah.
So it's important to be able to express these permissions. And the way that we generally break this down in SMART is we say there's capabilities in the underlying system, and those we don't try to model in a standard way. We just say the underlying system is responsible for supporting, for example, the idea that Mark as a user has access to these 3 patients because they are his children, or he's a designated representative for them. That's an example of something that can live in the underlying authorization system. Another example here would be the fact that this particular OAuth client is associated with a certain group. That's a policy that could live in the underlying system. And if you manage to factor it this way, then your scope could just say, when I get this particular access token that I'm going to request right now, this access token will have, the read scope on all kinds of patient resources. And what that means is all the patient resources I'm allowed to access. And which ones is that, which specific patients is that? That becomes an underlying system capability tied to a group. And I think that reflects a pretty common practice that we're seeing from the certified EHRs that are meeting the ONC rules, because what they're required to support is client registration and then the export of data within a group. And so the typical flow here is that at registration time or just after registration time, your client becomes associated with one or more groups. And then you can call export on those groups. And if you try to call export on a different group, even though you won't have the ability to call export on a group that you're not associated with.
Right. Yeah. Cool. Thanks.
Josh, what do you think about other more complex operations? Because group export, $, everything is more or less kind of like a query to a certain extent. You're just asking for a data. But there are much more complex scenarios. For example, if I define $ prior authorization submit, I don't know exactly what implementation might be behind the scenes, because someone might use temporary resources like task resource, for instance, to store some status of how it goes. Someone might not. Someone might store claim resources in the FHIR repository eventually just to reflect them. Someone might not. So there are too many nuances on the implementation, and basically from Smart on FHIR scopes level, it's really hard to say which scopes you need, because I would just say, and the use case is quite straightforward. For certain, kind of providers, I may just say, I'm not giving you any access to my resources in my FHIR repository. I don't want you to come and do any queries, but I'm giving you just this prior authorization endpoint. This is all what you have. Submit data, and I even don't want to tell you what I do behind the scenes, which resources I do write, read, and stuff like that. I might not even have like real FHIR server behind the scenes. You see, it might be like just endpoint doing some magic. So with that, just my opinion, we need somehow to say these endpoints are open for you, these are not. And even in Mark's example with we have member match operation in the scope of pair to pair. But what I would do, I would say, yes, endpoint is sort of open, because before you do any data extract, you need to find these members. But I would say I have these 10 client IDs that I've assigned for pairs, and I want only pairs to call this member match operation as many times as they want. But if it's some third party, iPhone app, I don't want it even to try it. It just doesn't make sense, because even the data is safe enough, it will be just, useless connectivity and stuff like that. So I would say, I want to say for certain clients, which operations are accessible in general, it's really convenient to get this level of abstraction. I'm just sharing some, experience from P2P and from...
Yeah, no, I totally agree. I think the challenge is figuring out how to standardize these. So, my only insight here would be to say, there are some kinds of operations that boil down to simple data reads and writes. And for those, we should try to model them with simple scopes that talk about the data reads and writes, instead of going up to this level of an opaque operation ID. But as you point out, there are other operations that can't be modeled well that way. And for those, I think just treating the operation definition itself as an opaque label and saying, great, you've got access to this thing. The server can easily manage that by tracking the operation definitions it supports, and just use the operation URL as a scope. That gets you reasonably far in terms of what I think is kind of the efficient subset of this that we can standardize. If you come back and say, well, yes, but we want to provide access to the prior authorization scope, but we also want to say in a standardized way, in band, that it can only be called with input X in the first position and inputs that match regex Y in the second position, there I look at this and say, okay, I think we won't be able to standardize at that level. So there's some sweet spot beyond which it becomes really difficult to get consistency. But I think for the examples that you just described, Artem, that is something we should be able to model pretty effectively with just opaque operation definitions as scopes.
Yeah. I think it will basically cover the most of use cases that they have, because you see kind of basically, I would say, from payer's perspective, there are three type of actors that can connect. It's another payer. I define this client ID is for this payer A, and this payer can do member match, export on groups, because I don't want even maybe to query my data. I expose group export, and this is enough. And I say, this is prior auth for you, maybe something else. I don't remember what's applicable. Next, I say this client is for provider. So you can do provider access API. Maybe you can do something with CDEX or something else. And like custom applications, like mobile phone applications, they do $ everything and standard queries. And in order to reconfigure them, I just need to define operations. They can come to my server, and that's it. So it's quite straightforward for me.
Yeah, I think that makes sense. And the other possibility that this raises is, in addition to providing scopes that pertain to one operation definition, you could also think about modeling those client abilities with a capability statement. These are the operations you're allowed to call, bake all of that into a capability statement, which has a canonical URL, and then use that canonical URL to sort of encapsulate the whole set. So if you find yourself having to come up with long lists of scopes every time, maybe you just want to summarize it and just say, this client is allowed to do the things represented by this capability statement.
Yeah, by the way, this is really good idea, because so far I've been thinking about it from the perspective of like having one capability statement in terms of what the server generally, like a max possible variance can do. But this is actually wrong, because any pair connects to another pair. They don't even need to know what it's capable of doing. You just need to understand if I can do pair-to-pair and prior auth, for instance. It's supported. Okay, I do these operations. I don't need anything else. Yeah, this is a good idea, actually.
Okay, guys, sorry for interruption. At least we have one good discussion. So let's think it was the first part of Roundtable.
Thanks, Josh.
A very interesting topic. So thank you, Josh. Thank you, guys, and let's move forward. Mohammed, your turn.
Thank you. All right, can you see my screen?
Yes, we do.
All right, so I'm going to speak about data segmentation for privacy. This is basically kind of very adjacent to the conversation we had with John earlier on, and there is a lot of overlap between how consent enforcement works and data segmentation. So hopefully this puts in context some of that earlier conversations. So security labels are metadata associated with a FHIR unit it could be a portion of a resource, as I will show later. It's a placeholder to mark additionally protected information. So, all health information are covered by blanket policies that require them to be protected, but there are specifically sensitive type of information that require additional protection. And that's how data segmentation works, by assigning these labels to identify that data and also leveraging that metadata to make the additional measures for data protection. So the metadata can be referenced in policies. And so there are examples of that in the US jurisdiction. I think the oldest one is the substance use data that's been around for almost 40 years, I think. And then there are new emerging types of sensitive information, depending, on the sort of cultural landscape and things that are considered sensitive by the consumer expectation of privacy. These categories could be variable and could change. So the key components in a labeling or data segmentation ecosystem, first is the tagging of the data. So that's where there is a security labeling service that I will speak about a little bit. That's where the data tagging takes place, as assignment of labels to data elements or data, in the case of FHIR, resource or bundles or element level labels. And then recording these labels, meta.security in FHIR is where the labels are recorded at a resource level. But it could also be inline labels for portion labeling that I will speak just in a few slides. We need standard vocabulary to use for the labels, basically how to say that, what is the word that we use for identifying, for example, substance use treatment. And that comes from the HL7 terminology, and some of those are categories are sort of referenced in the FHIR DS4PIG as well. And then there's the label metadata again. I will speak about this a little bit later. Label metadata is basically the additional metadata associated with labels that are useful for different use cases and also for the implementation to function properly. And then on the other hand, we have the consumption of labels, basically how we process the labels. So the first and foremost is to incorporate the labels into an authorization decision. An example of that is consent enforcement. And I believe the next talk is going to be about label-based access control. I suspect some of that is going to be covered there as well. It is also other workflow decision other than authorization that can be relying on labels, navigating or routing the data differently in a workflow, in a business workflow. And then at the sort of more superficial level, the incorporating labels into the user interface and the user experience. So, masking a data item or marking it with a watermark or something like that. I'm going to focus on one type of security labels. If you look at the FHIR DS4P, there are different categories of security labels for different purposes, but the one that's most prominent and most pertinent to this conversation, I think, is the basic idea of sensitivity categories is basically to be able to use abstract labels that would encompass more lower level clinical concepts. So we have these very specific, in the record, and we want to use these more higher level language in common language, understandable to the patient labels in order to put a marker that this particular data item falls into this category. And this will enable the articulation of policy at that high level. So a patient can say, I don't want this data to be shared in this category of data, rather than having to single out different clinical concepts or individual data items. The assignment of security labels by the security labeling service is basically a mapping at its most rudimentary level. It is a very naive implementation to basically do a mapping from these clinical concepts into those categories, in these abstract categories. And basically, this boils down to having a value set or a terminology slice that would be used as a lookup table to assign labels. And this is the most basic level of security labeling assignment. And then there are more sophisticated technologies emerging, large language models, and also counting in the other contextual information like the encounter context and other related resources in order to be able to have a more inference-proof kind of labeling. Aside from assigning labels at the FHIR resource level, the DS4P defines a mechanism to do inline labeling. So an example that's in there, I think it was actually from a real use case for a shelter, that someone is staying at a shelter and the residential is where they're staying is confidential, but that confidentiality doesn't apply to the entirety of the patient record. And it should be also distinguished that, the mailing address is okay to share, but the residential address has this sensitivity. So this requires some kind of a sub-resource labeling at a portion level. And the mechanism designed in the FHIR DS4PIG is to use a resource level marker that there is inline labels to process to trigger basically that deeper inspection of the resource, and then use an extension to record the label in the corresponding portion of the FHIR resource. And then as for the metadata, I think there's a few that are identified in the FHIR DS4PIG. We have a mechanism to record who performed the labeling. That could be the identity of the organization or the software, like the particular version of the software that actually invoked the labeling. The basis for labeling, the regulation or whatever jurisdictional or organizational policy that requires the labeling can be recorded as well. There's also a standard API for labeling, which is something that I will mention a little bit later, as a gap in the current specification, and we're hopefully working on providing at least a draft for a standard API to use this labeling service, basically to submit a resource or a bundle, and then the mode or the sort of configuration of how to invoke the labeling service in the system. Another way to do this is to configure it in a way that is the labeling takes place offline. So we have like kind of a batch or bulk labeling as data comes through the system through an import or data gets created or updated. then the labeling service is invoked offline and the labels are assigned. This also enables, especially like this doesn't apply to FHIR a lot, but in a lot of older documents, there's a lot of unstructured text. And that would usually requires additional processing that could be time consuming. And that is best done offline outside of the context of the transaction. But then there is the side effect of that is that we will have to update the labels when the data changes, and there's always a challenge as to guarantee that we actually have the correct labels at the time that data is being requested. And also we don't have the context of the transaction. We don't know the recipient of the information. And some types of labels like handling caveats, like you want to say, you can receive this data, but you have to remove it after use, like delete after use. This is an example in the FHIR core. That would not be able to be dependent on the identity of the recipient because we're doing this offline and outside of the transaction context. So I wanted to just do a very quick touch base on the consent enforcement and how it sort of overlaps with security labeling. So the first step is, as it was covered in the earlier talk, the consent rules can depend on security labels. And this is a very powerful way for patients to actually craft their expectations of privacy. So instead of having to say, this individual encounter or this individual data items, identified by their identifiers or specific clinical codes, they're able to say something that is very close to their expectation of privacy using a natural language. I don't want to share any reproductive data, for example. And so that's part of the policy that would be in the consent. It would be in the advanced category, in the categorization, the maturity models of PCF. But then at the time of enforcement, we need to be able to enforce this policy, which requires to take into account the labeling of the data and matching that against the policy. And that requires the labeling to be invoked on the data that's at stake to be shared. And as I said, this can be taken place offline, but the diagram that I have here on the screen basically shows how to do this at the time of transaction. So when a request is received, basically the general authorization service invokes the consent enforcement piece, and that would trigger the security labeling service that would actually apply the label on the data that is being requested. And then that enables the consent decision service to actually determine, what part of the data can be shared and whether or not, the transaction has to be declined entirely, or, some of the data that is not okay to share based on the labels should be plucked out of the outgoing transaction. So it is possible, for example, to take a bundle and then take out some of the resources that are not authorized to share, and then still respond with an OK response and share some of the data. So, and finally, I wanted to cover some of the challenges and gaps. So we have currently we have HL7 specifications for data segmentation, but we need active updating of these and active revisions. I think the DS for PIG has not been updated in a couple of years. There hasn't been active working on the FHIR DS for PIG. So it's sort of like a snapshot of what was supported at the time. The other aspect is the terminology. I think this was a major challenge when the ONC was kind of considering whether to require some level of data segmentation. The codes that are in some of them are not granular enough and kind of lump in some categories. So there is also this need to overhaul that sensitivity value set and also define new codes and also provide guidance as to what would be the corresponding or the standard label to be used for each of the sensitive categories that are identified in the jurisdictional policies in the US regulations, for example. Another area that I know multiple groups are working on is to identify value sets of clinical codes that could be used as a starter kit, basically, to identify what constitutes, for example, reproductive health data or what constitutes substance use treatment in terms of the clinical codes that in the content of the record, and having a level of consistency across different implementations so that there is a common understanding of what would fall under each category and a consistent enforcement of that across the board, between different providers. And then finally, I mentioned this earlier that we do need a standard API for SLS to be able to request labeling and get the response back together with all the metadata that's required. And that's something that we are working on. There's an open ticket right now in the security working group. We're hoping that we will have some kind of a draft to be added to the FHIR DS for PIG. So I'll end here, and hopefully I did well with time.
Thank you, Mohammed. I'm still curious about this security label. So this is kind of technical framework, yes, to like which introduce a layer of indirection, and just from like top level views of, so the most of labels are deduced from existing information or some policies, yes. So it's like a derived information, and I see a lot of intersection with a kind of terminology stuff like value sets and all the stuff. What's the real difference between observation.meta security and observation.code? Yes. So we're gonna deduce sensitivity labels from observation.code, or we will have like value set, and if you match this value set, then specific sensitivity code will be assigned to resource. I mean, this kind of section. And
so I think this, this is, if I understand the question correctly, there is a lot of innovation that can take place there. I wanted to point out that, the very rudimentary, like the most basic level of doing this is to do that lookup. Like look at the observation, look at the code, look it up in the terminology, and see if we have determined that belongs to one of the sensitive categories, and then apply the label. But that sometimes doesn't work. First of all, it's not inference proof. So you might be like, there's a context that can actually lead to, there's other observations in the same encounter. There's other data that seems innocuous, but altogether considered could actually lead to inference about that sensitive condition, even though you plucked out one data item, right? Taking into account the context of the encounter, the related resources, and also sort of weighing these, there was an example in one of the demonstrations, or it's a kind of a pilot that we did many years ago, that, medications that are innocuous in other contexts could actually be used in a substance use treatment facility. And the combination of that medication with the rest of that context could actually, you look at this and like, this is a regular medication, it's not sensitive. So you can't say that globally that medication per se is an indicator of sensitive information. But within particular context, it could actually be sensitive, and that needs to be taken into account into the labeling as we move towards more advanced labeling services.
Yeah, thank you. And John, Mohammed, can you tell me, so what triggered you to start this labeling, security labels framework?
I think John is a co-chair of security workgroup and has been around much longer than I have. So
yeah, actually, the impetus that even predates me and it comes from military applications, so secret, top secret, those kinds of things, and how data are even in those places assessed into the various categories. So that's kind of the impetus. It really goes back to that. There are certainly models called attribute-based access control that are foundational to what this is all about. But as I point out, attribute-based access control quite literally means use any attribute you have, and a security label is a particular kind of classification and done by some classifying entity. So yeah, it comes to us from the military space.
Are security labels context dependent? So if I'm in different contexts, can I get different set of security labels on the same resource?
I think it would depend, yeah. So I think there are some types of labels, like sensitivity labels. I think they are rooted in the content and the clinical content of the resource. So that wouldn't change unless like the science of medicine changes, for example, that, this medication is now used for this treatment and that treatment is sensitive. So that wouldn't change in that case. But there are like confidentiality labels, for example, it's another level of reasoning on top of those basic clinical indicators. And so, let's say certain categories, I think for psychotherapy notes, for example, it is identified in one jurisdiction as sensitive data and not in another jurisdiction. So you would consider that restricted with the confidentiality label of restricted, but it wouldn't be restricted in another jurisdiction where that policy doesn't apply. But the fact that it's psychotherapy note doesn't change. It is based on the content resource. And then further to that, there are at least there's a category of security labels for handling instructions. or handling caveats. And those could be dependent even in one individual transaction. So you're saying that this particular recipient needs to follow this handling instruction, and it only applies to that recipient. It doesn't apply globally. So it could be even context dependent in terms of individual transaction or individual recipient.
And in general, this labeling service should have access to the whole patient record to make decision or even more.
Yeah.
So this is, I know there are some clinicians in the room here. This is one of those classic dichotomies, right? And so the reality, you know, I'm sort of parroting the arguments that I've heard on both sides. The reality is that clinical decisions often take place with not complete knowledge. Like there's always, you know, things missing and there's partial knowledge at the time of decision making. So that's one thing. And the other thing is that you know, having that or empowering the patient to have that trust in the system would usually give them the ability to actually share more if they have that confidence that this system is going to honor their wishes. So if they, you know, this was something that I read from one of the results of a focus group, that the patient would be like, I wouldn't want to share anything if I thought anybody in the hospital would get access to that. But if I knew I can only, you know, share with my doctor, then I would want to share with my doctor. So having that granularity and control, both arguably and also based on some evidence of data, would encourage patients to share more and have more confidence in the protection of their information. I don't know if you want to open this. I'm sure there are other people who have opinions on this, and they could also provide some input on this.
Thank you. So maybe let's have a last speaker and then round table. So Mike, are you ready?
Yeah. Thanks a lot. Thank you so much for the introduction, Nikolai. My name is Mike and I'm a product manager with the 8box FHIR platform. So technically Nikolai is my boss, so he knows what I'm gonna talk today about. And Nikolai, if you would like to contribute, please feel free to do it. You see my screen?
Yep.
That's great. So my talk will be mostly focused on implementers side of all this stuff. We have recently introduced a label-based access control in 8box. There's a story behind that I will tell you. 8box is a FHIR backend, and the access control is a very, very solid layer of this. Historically, our customers used access policies to define the access to the resources, and basically it's attribute-based access control. Our customers reached out to us with the questions on, can we handle the cases with confidential and sensitive data in 8box more easily? And the answer was, from our side, the answer was definitely, why not to use FHIR security labels to do this? Because looks like they were built for this. So as previously was told, like FHIR security label is just a concept attached resource or a bundle meta that defines some additional security information about what it talks about. So taking this knowledge on one hand and putting it into the flow, it looks like this. So we can build it enhance our access control layer with a pre-built security labels flows. So if a user has enough access and he or she is calling for a specific resource that has a specific classification, and the confidentiality or sensitivity layer is okay. So what we are doing is we are providing a user access to the resource. But if not, for example, if the user doesn't have enough access rights, what we're doing is just we are saying, no, it's not possible for you. Quite easy and understandable. What's good, and the core FHIR brings confidentiality codes. This is just a classification that contains 6 codes, from very restricted to unrestricted, hierarchical, meaning that if a user has access to very restricted information, he or she will by default have access to less sensitive and confidential information. And sometimes this is not the right case to handle the cases when, for example, 2 providers should have access to observations, for example. We consider observations like a very restricted or restricted information. But what if some observations contain information about pregnancy or child abuse information or whatever? We definitely don't want both providers to have access to this. That's where the FHIR data segmentation for privacy IGA comes into play. Implementation guide basically brings additional vocabularies that allow us to segment, enforce access to specific information depending on the context. The most interesting cases for us here are sensitivity and compartment, because there are definitely cases when for example, I want to provide access to resources or resource elements for providers but I want to provide access to different resource element to research departments or any other people. So basically how it looks like. A resource, it was shown previously, but I will just show it once again. We have security here, system code, and display. That's how it looks like with just confidential code. Very easy. But what happens managing access to the resources or the bundles is not enough. What if we want to manage access to resource elements? For example, I have a patient resource with an identifier and name, and I want to share a masked information or strip the information to the users that don't have enough access rights. So for example, if our name is normal, and the access level and the identifier is restricted access level, what can 8box or what can system do? The first way is when a user comes in with a normal access level, we are just sharing the name elements and we are masking identifier elements. We do the masking uses data absent reason extension. So basically, a user will see a name and an extension with a dot, or we can just strip it. It can lead to different consequences, but I will talk about it later. Again, very simple. Inline security labels, they require to add the process inline label to the resource meta and security labels on resource elements via standard extensions. That's how it might look like. There's a resource type encounter, there's a specific code that we want. Besides, they are working in pairs, like in confidentiality and these sensitivity codes. What we want to do is we want to put an extension for these elements. How will system, it will provide you the security meta, and will give you an extension that's a standard extension with a data absent reason and value code mask. But when we were designing this with our customers, we came across one more solution, and this is how it might look when we just strip FHIR security labels, because the security labels basically might be a data leak. So all these technical implementations and our discussions with the FHIR community and with our customers brought us to a very serious trade-offs between medical safety and data leakage. After long discussions, I just want to put some facts here, and you can definitely check the FHIR chat discussion. I'll put the link, but they are definitely an organization make a decision on themselves. The trickiest part is that the disclosure of data absence can sometimes be a data leak. So when I'm telling to you that the element or the resource is redacted, it might mean that I do have this resource. And when it comes to a very sensitive information, what happens? You know that I have it. So there should be very tough decisions before doing this. So, and on the other side, for example, if we do not provide sensitive data, what happens if a provider doesn't get enough data to make a clinical decision? That's another point of the problem, and I think there will be some place for discussion on the roundtable after my talk. Another problem that we came across basically is privacy versus conformance. Again, a rabbit hole. But what happens if we modify requirement elements in FHIR resources with data absent reason? It will lead to non-conformance. If it's conformance for the sake of conformance, that's totally fine. But what if a client relies on the data structure? How does it work? This is also not yet finalized question. So the current state of the implementation in 8box looks like this. So we have a security labels enabled mode that basically, if a resource has no security label in it, it's not available via API. Once we've done this, we came across different interesting, for example, a user once trying to log in for the first time, doesn't see any resources, either FHIR related or custom resources. And that's why we came up with a super admin role that has to the instance. But that was not so obvious for us when we're doing this. Explicit security labels. 8box expects explicit security labels from external security labeling service. I do want to see, and I'm looking forward to seeing a security labeling service that does everything on the fly. I do believe that a bunch of our customers will have quite a lot of questions to the performance of all this stuff, but that's definitely what's worth talking about. And one more thing is that, as I mentioned, security labels by themselves can be a data leak. So 8box provides a mode that strips security labels from a resource totally. What are we gonna do next? Definitely there's a lot of place to talk about rules for labeling and access control. So to be more dynamic, not static, but static works. I'm not sure about dynamic. Security labeling services that allow us to do it on the fly. And we are definitely looking forward to implement more data segmentation for privacy cases. And if you have any cases in your mind or challenges you see, come to us to talk about it. That's it. I have a small demo. Not sure I have enough time to show it. And I would like to just...
You maybe can show to the people how they can do it by themselves.
Sure. There's a wonderful place to do this. It's called 8box documentation. So it shows a full demo. I can just be very brief. So
okay, we have some time.
I have an 8box. So it's like... here. See my screen? It's posted. So I have a locally running 8box and I have two clients, one for provider and one for like some finance guys. What we are doing, I wasn't talking about how of the context of a user. So how do these security labels come to the 8box? Right now, it comes with a JSON Web Token that contain the access levels. So what we are doing in 8box, very simple. We are creating a token introspector resource that parses the token. We are creating an access policy that basically is very simple. I allow to do FHIR read and FHIR search operations and putting some dummy sample data here. But what happens? So a patient resource, an encounter resource and observation resource. But what happens next? When I start calling this from another user, where I see genders, but I also don't see the name. For example, I'm a guy who does some analytics, so I want to get the genders, but I shouldn't get any names. When we are starting to call for observations, for example, again, it has a reference here, and here I don't see, so I see neither an identifier nor a name. So that's here. 8box can be quite easily loaded, and we are welcoming you to come and play with it. We can share this Postman collection, and there's quite an extensive documentation on our site, and we are totally looking forward to discussing these cases with you.
Thank you, Mike. So let's move to the discussion part. And I have one question to Mohammed. So and John. So this care team label looks like it should be assigned on fly. Yeah. So I could not interpret it. So if we like the security label care team, that means that you should be in care team to see this data. How you expect that it should work? I mean, how server has to behave. So let's say, okay, I'm doctor who is requesting data and I'm part of the care team for this specific patient, and I'm not a part of care team for different patient.
Yeah, I'm not familiar with the tag you're speaking of.
Yeah. Okay, sorry.
Yeah, I mean, quite literally, there are some vocabulary terms in the HCS that are quite, a mystery to me. They were put in there, long time ago and whatever. So, the codes are not all that well managed yet.
Yeah, because for me, it looks like it should be dynamically calculated based on context. So if the provider in the care team, then it has this tag.
Yeah.
It's not, and it's kind of technically hard to implement. So.
Right. I'm not familiar with this code either, but my kind of off the top of my head understanding is that the idea was to restrict the visibility of the data, like for the recipient. So you receive this data, but you only make it available to the immediate care team of the patient and not broader.
Yeah.
So that is what I understand from it, and the application of what that means, who is in the care team or not, is on the recipient's access control system.
Yeah, there's certainly the concept of this data is only available to care. There is that concept, and in fact, I kind of learned of this concept probably a dozen years ago with the NHS looking to define a service called legitimate relationship, which was a service they were proposing that the access control could call based on the user who is requesting data. Does this user have a legitimate relationship to this patient? And that was supposed to cover things like whether ADT had tagged this clinician as part of the care team. It was interesting they ended up killing that because ADT was happening too fast for the service to keep up, and therefore it the computing wasn't available at the time. But I think I certainly have seen the concept, but I haven't seen it a security tag.
Yeah, thank you. Anshu, one small question. So what the right approach? It is quite common scenario to say, so the policy that the provider can see the data of the patient, which this provider related to through care team or somehow else, yes? So what are recommendations to describe it in FHIR? So how it should work? I mean, in a generic FHIR way. Do we have a tools to describe this or not yet? So and it's out of scope.
I think if you were to look at the FHIR list of resources, care team resource itself could theoretically do that, but that would mean you would have at least a care team resource for every patient. And this starts to, question the scalability of that solution. So, a hierarchy of care teams, I don't know that I haven't seen any particular good answer to that question.
Anshu, so.
Yeah. Thank you. So similar to this question, I am also kind of introspecting, deliberating within my team, how to implement security label for care team, wherein somebody is working on behalf of a provider to restrict certain data element to show if the person logs in as on the behalf of the provider, not show everything. So probably that data element on behalf of could be the answer, but just if you can throw some light on this scenario.
Using the care team as a security mechanism is a great thought. It seems like the care team is more supporting conditions. That's at least my opinion. I spent about a decade in the payer system, and we struggle with the same thing. We wound up putting in a lot of custom security around at the application level and then, either the admin of the provider side or the admin of the payer side had to, do their security forms to fix that. That's how we solved it for, tactically for how to make sure that they had access within the app. I don't know about others, but that was my experience.
Yeah, thank you, Mark. John, do you want to add to answer something?
No, I think this is one of these where the default today is treatment. Does this user have a treatment role? Yep, good, they're in, which of course, comes to head immediately when you get with VIP patients. So, with VIP patients, you then have this relationship of the VIP security tag on that patient and whether the clinician, has a VIP relevant permission. So I think I just don't know that there's a clean way to deal with it. And I think the other piece, and maybe this was also what Mark was kind of getting at, is it's such a fluid thing, the I am helping this clinician out because I was, he pulled me as I walked past in the hall, that's not going to even be known by ADT, to go back to this NHS legitimate relationship service that just couldn't keep up because ADT was overwhelming it. Yeah.
We're looking at this in the provider access API because that's driven by, it's relatively simple. It's on the payer side, but it's looking at basically the attribution list, which you can derive an existing treatment relationship by, for example, looking at claims history and seeing, yes, this practitioner's worked with this patient. We've got to factor in from the patient. But what we're also looking at is with the prior authorization, there's a bunch of hooks. And could some of those hooks, like encounter start or even appointment book, be an input to some sort of real-time attribution list maintenance process where effectively the group resource is the attribution list that defines everyone that the practitioner or particular individual has access to.
Something like a legitimate relationship service that returns, a 1, 2, 3 kind of evaluation. Then you don't have to say that this is the data layout that service derived a direct relationship or an indirect relationship from, but that allows it to spelunk through whatever data it needs to, even if that means it's spelunking through proprietary databases and in addition to the FHIR data. I just don't know that in FHIR there's a clean resource that covers the space. That's all my point is.
Longer route, what I was thinking is, like, see, if Epic provides if you build an application, Epic provides patient category application, then they merge provider/care admin, or this, I don't remember the term now. They ask you what kind of application is that, right? So I was thinking, I mean, if the care team or admin has to access, shall we bring another different application and address it that way to have different level of data access, right? So I was thinking from that way, if that solves. But thank you.
Yeah, I have a topic to discuss. So let's say we have data exchange working between all organizations, and how should consent follow the data somehow? Because, okay, I'm organization A, I'm sharing data to organization B. So the data moving from A to B, should the consent or some security consideration walk with the data to different location and then be applied there? And another problem, it's terrible, but can I revoke the success later if I decided eventually that I don't want for this system to have access to my data? Or in case of TEFCA, yes, so if like multiple systems get access to my data, I need some operation to revoke access.
Yeah, I think this is a really good principle, right? People should be able to decide where their data goes, and then if you make a mistake, like you should be able to change your mind later, at least for the good guys, right? Like it's never going to be the case that you can tell the bad guys to stop using your data in illegal ways. That's not a policy level decision. But, I'll say practically, one way to get a little bit more of this behavior in systems is to do more with data on a transient basis. So rather than expecting that somebody's going to grab all your data, use it for one purpose today, and then keep it forever, and also follow your rules and keep following your rules, you might move more towards operations where you make your data available on the basis that you're going to use it right now and delete it. And you can come by again automatically tomorrow if you need it again. But then there's sort of more one source of truth that people have to keep coming back to. And we may see more and more services that will bundle compute with the data. So, there are some use cases where I don't need your whole clinical history. I just want to compute this risk score. And the fact is, nobody will compute it for me. I've got to do it myself. So the only way is to first get all the data. But you could imagine, more services being offered that bring the compute closer to those data.
Yeah. And I know from a consent side that the Karen Alliance is working on some of the consent piece around the patient itself. That's come up as an issue for us to tackle. So I think and Josh, I think you were there too when they were talking about it. So I'm expecting there to be something that comes out of that conversation.
You can do that kind of a thing where it's like, okay, the consent just changed and now everybody sees that new consent. Historically, that's been a very difficult thing to do. And it's related to, I think the big point here is we are dominantly watching treatment-based workflows for which so much of what we would like to put into consent rules just simply doesn't apply. Payment, at least there are some kinds of cases where payment can have these kinds of interactions. You get into operations, you get into research, you get into, these other things that become far more. One, to Josh's point, I would love to see that kind of a thing. Again, I think in a treatment use case, it falls apart because if I have made a treatment decision and I'm instantiating that as a decision, I have to hang on to the evidence. But if I move away from that, then absolutely, computing a risk score. There are obligation codes that can easily be applied at the bundle level to say, hey, I'm releasing this data to you. I have the authorization to release it to you. All of your stuff checks out, but I am going to include the obligation that you cannot persist it. So in theory, I have that ability today. Now, I clearly wouldn't want to tag a bundle with don't persist if I didn't think that you won't follow that and not persist. But there are some of those obligations codes that are available for these kinds of things, like don't persist, or if you persist, encrypt it, or if you persist, a further consent is necessary to do anything else with it. So there are those kinds of obligation codes. And then on a little bit more complex side, we're working on, in the HL7 security space, we're working on adding a permission resource. And one of the prime use cases that interests me with the permission resource is I could attach the permission resource at the bundle level and say things more complex than do not persist. Like I could say, it's okay for you to hang on to this for 7 days. but then you have to discard. So I can put in conditions in there. I can put in variables, those kinds of things in the permission. Again, it doesn't help to just attach this to a bundle if you don't know that the recipient of that bundle is going to look at it and abide by it. But having the ability to communicate those obligations or those permissions, those restrictions, is kind of what we're trying to add with the permission. I think a lot of proof will be in the pudding there. It's awfully academic at this point. We are working through some use case analysis rather than just simply putting it out there as theory.
Thank you. Any other topics? Josh, maybe let's discuss this like patient in the middle idea for exchange. I think if I would be the patient, I would love to know what's going on with my data and participate in.
Yeah, I mean, it works both ways, right? Like there's obviously scenarios where if you were the patient who had just been in a ski accident and you're unconscious and somebody takes you to the emergency room and, you know, your phone was destroyed when you hit a tree, like you still want the care team to be able to figure out what medications you need to be on. And I think, you know, most everyone sort of agrees with that perspective. So the trick is figuring out how to allow patients to be in the middle of these sharing loops for the vast majority of scenarios where that makes sense, and you know, not totally break the system where you need it in emergency cases. So John pointed to things like break the glass, and you know, that's sort of a reasonable domain if you can make the use of it small enough that it can be meaningfully audited after the fact. But if your everyday sharing pattern is one that involves just sort of trust by authority, you can't really audit that very well, or at least I don't see evidence that it's being audited very well. These QHINs go through the network to look up a patient versus being able to connect directly to a healthcare system that has data about the patient. Today, the only data flow that's actually working in TEFCA is one that where you go through the QHIN, the Health Information Network, and they kind of broker the connection to individual care sites. They manage the lookup functionality and route your messages back and forth. In that scenario, they've got a pretty good ability to at least create audit logs, and they're required to create audit logs, but they're not required to share them with patients. So for me, like that's like the number one smallest step that we could take is these large organizations, there's only like on the order of 10 of them, it's even fewer than that are already maintaining these kinds of logs. They should have some responsibility to share them back with patients. That has been really tough because you know, those organizations are already perfectly busy and have a lot of other responsibilities on their plate. They don't have any patient-facing infrastructure at all. They're pure backend stuff. So they say, well, it doesn't make sense for us to offer this service. Maybe. So anyway, that's the narrowest thing that I think could help. But then we get into this world of point-to-point sharing, where you know, a TEFCA member over there, they want to talk to each other about a patient, but they don't need to go through the QHIN if they're just writing FHIR queries. Now, FHIR exchange is not yet happening in TEFCA, so I'm just describing how people expect it will work. But what people expect is that that point-to-point connection will happen without any involvement from the QHIN, and so it's not clear sort of where the audit logs would go. Now, again, one straightforward idea in my mind would be you can still impose audit logging requirements and make the QHINs responsible for them. You could say, if you're going to share data about a patient under TEFCA, even if it's part of a point-to-point transaction, you could still send an audit notification to your QHIN. And that way you've got a complete record somewhere. Again, this idea is not at all popular. I really can't quite see a way to bring this into reality, but to my mind, it really would help go a long way towards solving that transparency problem.
Amen.
So what do we do about that? I'm not sure.
Yeah, that's a good point. Yeah, maybe even not restricting information, but at least know what's going on. Yeah, and who is using your information.
So I do see, so like within my personal health portal, which is Epic, there is a log of accesses to my data, but
yeah,
it completely falls, you know, to pieces when you start getting external bodies involved. And of course, I can't really know to what extent it's depth. I think one of the problems is that to get exhaustive is to overwhelm. And I think there's a concern about overwhelming, for which my response is, yeah, if you can overwhelm the patients with too much logging, that just creates an app space opportunity for, you know, an audit app that watches your logs and looks for unusual behaviors, because yes, you've been to this doctor 12 times. You didn't need to know that, he saw your data again today. So I think if we can open the floodgates, we create an opportunity. But I agree with you. I don't see the motivation to open the floodgates yet. It's expense. There's no benefit. There's a drawback because then the patient can say, "Oh, hey, who is this practitioner 1, 2, 3, 4?" And now they have phone calls that are asking about information that they really don't want to answer.
Yeah, I think there needs to be some agreement on the principle, and it needs to sort of make its way into the formal charter of these networks in order to have a chance of actually happening. It's not something that's that easy to bolt on to an existing exchange system. Technically feasible, but getting people to come along for that journey is tough.
Yeah. Now, on the topic within IHE, I do have the basic audit log patterns implementation guide, which defines for the RESTful operations. How would you log those? And if you logged those, how would a client have access to them? It's very, rudimentary, but it's been implemented by a couple of different FHIR servers. So it's an opportunity, again, if you open the floodgates, applications will come along and start adding analytics to this data feed and going, okay, don't overwhelm the patient with all this, but oh, by the way, here's an unusual thing.
Thank you. Any other topics to discuss? Guys, feel free to unmute yourself and ask the question. Josh, any way for security labels to be incorporated into Smart on FHIR, or it's enough security parameter will work?
So we had a lot of discussion about this in the original Argonaut project when we were designing the granular scope language. And there is a slot for saying this. So to the extent that an underlying EHR knows about security labels and can enforce them, you can include them in your smart scopes. So you can say, I want all observations with a security label of X, or with a confidentiality label that ranges from low to medium but not extreme, right? There's a few different classification systems. The challenge has been, even though we can express these labels in our scopes, that doesn't mean that real world systems will be able to enforce them correctly. So we've been really reluctant to try to suggest or require that until we see some evidence that systems are able to enforce. Even getting these category level enforcements is taking time.
And one of the challenges I grappled with when I was trying to do this using FHIR queries, basically, to be able to actually apply to smart scopes, is that you kind of hit a wall with the FHIR query limitations. At least the kind of FHIR queries that you can do inline as a get query, like there is a more advanced query language that you could use, but that's not something in the smart scopes. So if you want to have something complicated that would lead to like an and an or with security labels, then it's not going to be easily expressible.
Yeah, I think that's right.
Okay, guys. Any other topic? Everybody a little bit tight, yes. And it is interesting discussion about like operations and data, kind of two point of views, how to describe this. It remind me like functions and where the logic should live, like in data structures or in the functions, wrap it in an object. So do you think, Josh, you will choose one of them, or you will kind of try to use both these ideas?
I think we'll do a little bit of both is my best guess. I think there's going to be some use cases that are pretty well served by just being able to describe the data structures and the sort of read versus write. And for everything that's in that bucket, it's much cleaner. It's going to be easier to consistently represent those scopes. You can easily compute the overlaps. You can take unions and intersections. There's a lot of benefits to describing things by the data. But we've already heard there are plenty of use cases where we just have this operation or this whole set of capabilities, and we want to handle a name for that whole thing. And that's, in your analogy, that's like functions. So I think we want to at least be able to assign names to those functions. It might be that all we do in the Smart IG is say servers can use operation definition URLs and capability statement URLs if they want to point to those things as a set. So my guess is that we'll do both of those.
Because to be honest, when we were developing like EHRs and some APIs, so we call it like safe operations. So you can always design safe operation, which probably may use different resources. and quite sensitive, but you can hide all this logic behind the operation and just say, okay, you can call this operation, it's quite safe, you could not do anything bad with this operation, but you don't have direct access to the data which is used in this operation.
The only thing that I would like to ask you is out path of the request.
Okay, so that's some technical requirement.
It's breaking the HTTP.
Oh, you mean that they could be very long and you may hit limitation?
Not only, but especially when you're requesting, for example, patient.rf. Josh suggested to use read and set, but actually this is some sort of extension that means that file extension. By the way, it's
So those were only appear.
Assumes requested kind of request is already have some sort of, I don't know. This is file extension.
Yeah, so there may be some confusion about those scopes. They don't appear in a URL path. They appear either in a query parameter in an authorization request or in a JSON payload. So you're never like navigating to myserver.com/patient.rs with those scopes.
Okay, so that's small confusion. Yeah, and John, I have a question about permission resource. What is this? So is it kind of policy? So it's going to express the policy, and is it going to be machine readable? So can I put any logic into permission resource?
That's the vision. We're not quite there, but yeah, the theory is that permission should be able to cover all policy space that's not consent, and we even have the ability to have consent say, hey, my rules are in that permission. But yeah, permission is supposed to be a general purpose policy where we're trying desperately not to reinvent the wheel because there are policy languages out there. XOCML keeps coming up, ODRL keeps coming up. There's a bunch of these policy. So we're trying not to go off the deep end and reinvent that. But there is a benefit to having a FHIR encoding for some things that are very FHIR specific. So being able to point at FHIR resources or being able to use, the FHIR data types. But yeah, one theory is that it could, your whole policy, your overriding policy is the term we're using, could be completely rewritten in a permission resource. And then you just point at that permission resource to say, that's our base policy. And we're doing those kinds of use case analysis in a sub-work group. Based on that, we either propose changes to the permission resource or bring examples from that into the permission resource. But right now, we're just kind of using the IG publishing tool as a way to do use case analysis, not to write an IG, but as a way to do use case analysis.
Thank you. Is technically consent policy as well or not? Just philosophical question.
Yeah, well, that became one of the problems, right? As soon as we said, hey, permission can do any policy, they were like, well, why do we have the consent resource anymore? And the primary reason to have the consent resource is that it is specific to patient and it's specific to the ceremony of capturing the consent. So like I said, the permission has a set of rules within the permission. You could say, hey, I don't want to have two different ways to encode policy rules. So I'll use the consent resource to capture the ceremony, but the rules would be in a permission resource. So you'd have an instance of a permission resource that has the rules, and then the consent resource just points at that permission for the sub rules. So we do have that ability, but right now, yeah, we're unfortunately, we've got two different ways to do.
John, I'm just thinking whether probably we need to have value of an obligation resource. How do we deal with obligations which provide additional thing in addition to permissions for consent? Because consent is about patient, but also it provides obligations for some of the providers to fulfill the choices of a patient. So
yeah,
I feel
an obligation is indeed a policy, right? So some of the use cases that I've worked up for how do I use permission is, for example, to say, hey, you asked for data. Here is a bundle of the data that met the query you asked for. But by the way, I'm going to impose upon you an obligation to not use it for this, go ahead and use it for that, discard it after this amount of time. So you would encode that into a permission and attach that to the bundle so that the recipient would know the conditions under which they can use the information. So it's a more advanced obligation than the obligation vocabulary supports. So obligation vocabulary does support things like don't print, don't persist. You must get an additional consent, but it doesn't have the ability to say all three of those combined. So permission would be kind of that wrapper in that case. So that's one of the use cases for permission, in addition to the overriding policy of an organization. Another use case, which is protecting the branches and leaves in a provider directory, so it's provider directory specific. So we've got a bunch of different use cases that we're working through.
Right. But I was just thinking, if you're talking about generic permission, then there is a scope to talk about generic obligations as per even deontic logic, where obligations is statement that someone is obliged to do particular behavior, not necessarily consent, but something that you need to monitor in terms of tracking and things like that. So if you're talking about generic permission, I'd probably like to add a little bit more thoughts into obligations. And I think the work which we did with Mohammed, I remember it was HL7 consent service management. We did bring in the issue about obligations, permissions, prohibitions as coming from the logic perspective, and then informing how we can implement that in a system as a part of tokens, even that you can share among participants.
Yeah.
Anyway, just a thought.
No, I want to say it's in scope. We have to pick a resource name, and invariably that resource name doesn't work for some things, right? I mean, many people have complained that consent doesn't include dissent. Well, yeah, it does, because there's a permit rule versus deny rule. And other people said, oh, consent in my only applies to certain regulated use cases. Well, we have to pick a name. So with consent, we picked consent, and with permission, we picked permission. But in scope of what permission should be able to communicate would include obligations. Indeed, it would include forbidden. So the rule is really permit, deny recursively with obligations.
And there is a really nice link in the FHIR consent as external link to called policy by, I think, or external policy, where you can reference to external policy language, which is a really nice way to separate, even dealing with complex issues such as delegations, what happens when you have multiple providers, how I pass delegation, what patient has agreed from one provider to another, but you need to formalize that. I know it's a really advanced version of consent, but it is something that we talked about that a while back, a couple of years ago, with the HL7. So thanks for that, just a point.
Okay, so we're running out of time. So the last question to all the speakers and other leaders of community. Can you say what working groups exist, how to join these working groups, or at least discussions around like different IGs and specs? So maybe we can start from John.
So the HL7 security work group is where the security resources within FHIR are happening. We have a subgroup that meets every other week that is working on developing permission. So that's an HL7 work group. And then over in IHE, the IT infrastructure committee domain within IHE, I'm co-chair there as well. That is where we get PCF from and basic audit log patterns. So they do the security and privacy reusable implementation guides.
And what principle is applied that some projects are behind HL7 and behind IT?
Well, it used to be a lot more clear. HL7 did standards and IHE did profiling. It's less clear nowadays, but for the most part, I'm seeing mostly, well, obviously IHE is a profiling organization. So IHE is a place to create implementation guides. The advantage that they have over current vision in HL7 is that they can choose from any standard. So they're not limited to profiling FHIR. So that's why we have things like XDS and XCA within IHE, because we looked around at the standards available and found that EB registry was the best standard at that time to profile for that use case. So that's the benefit of IHE, is that it is a profiling organization. It will not create standards, but it's a profiling organization that can pull from any standards organization. So we pull from OASIS, W3C, HL7. So I just see that as a better place for implementation guides.
Okay. And definitely people can find you in a Zulip chat, yes? So there's stream for and ask any questions.
I love getting questions via email. I really boring. If you ask me a really great question, I'll probably move it into a blog article protecting you, but just because it's where I find reusable stuff. Yep.
Thank you. And Josh, can you tell a little bit more this SMART, because it consists now a lot of parts?
Yeah, so the app launch guide, where we define those scopes and the connection between apps and EHRs, that is work that happens in the FHIR infrastructure work group in HL7. And then there's a SMART channel on the Zulip site. And for Smart Health Links, similar story. It's work that is being taken into HL7 through the FHIR infrastructure work group. And there's also a health links channel or health cards and links channel on Zulip, which is the right place for community discussion on that.
Thank you. Do we have other projects?
So I wanted to mention, I think outside of the security working group, the CBCP working group is also then in the FAST group, there's an IG work group now to work on a consent management, which is all the aspect of consent outside of the enforcement of the consent and the decision making, basically. So I think there is some interesting work that's going to take place there. And then Sequoia also has recently started a consent and privacy work group. There's been a couple of meetings. I've attended those as well. And I think that's another venue where some of these conversations are happening.
Thank you.
Thanks for hosting. Take care.